Hi friends, in this ECG basic, today I will talk about second degree heart block, which is also called Wenckebach's phenomena or Mobitz type 1 second degree heart block. First is a disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Second degree AV block type 1 or Mobitz type 1 is also called Wenckebach's phenomena. Here in ECG we find progressive prolongation of the PR interval, which culminates in non-conducted P waves. PR interval is longest immediately before the drop beat, and PR interval is shortest immediately after the drop beat. Other features are the PP intervals remains relatively constant. The greatest increase in PR interval duration is typically between the first and second beat of the cycle. The RR interval progressively shortens with each beat of the cycle, and the Wenckebach pattern tends to repeat in the ratio of P is to QRS group with the ratio of 3 is to 2, 4 is to 3 or 5 is to 4. What we see is there is progressive prolongation of the PR interval, which culminates in non-conducted P waves. Means PR wave prolongs, then there is a P wave, but there is no QRS complex. The PR interval is longest immediately before the drop beat, and it is shortest immediately after the drop beat. And also remember that the PP intervals remains relatively constant, and the RR interval progressively shortens with each beat of the cycle. The mechanism of Mobitz type 1 is usually due to reversible conduction block at the level of AV node. The malfunctioning of the AV nodal cells leads to progressive fatigue until they fail to conduct an impulse. This is different to the cells of His-Purkinje system, which tend to fail suddenly and unexpectedly, which is seen in Mobitz type 2 block, which I will be discussing in my second video. The causes of Wenckebach's phenomena are the most common causes are drugs like beta blockers, calcium channel blockers, digoxin, amiodarone. Any condition which increases vagal tone, for example in athletes, we can see second degree heart block type 1. Inferior MI, myocarditis following the mitral valve repair surgery or surgery of the tetralogy of Fallot. All these conditions they lead to Wenckebach's phenomena, that is Mobitz type 1 second degree heart block. Mobitz type 1 second degree heart block is usually benign. It causes minimal hemodynamic disturbance, and it has a low risk of progression to third degree heart block. Asymptomatic patients, they do not require any treatment, but the symptomatic patients usually they respond to atropine, and permanent pacemaker is rarely required. Here in this ECG we can see progressive prolongation of the PR interval with subsequent non-conducted P wave. We see 5:4 conduction ratio of P waves to QRS complexes, and there is relatively constant PP interval despite irregularities of the QRS complexes. The first clue to the presence of Mobitz I block on the ECG is where the QRS complexes they cluster into the groups and they are separated by short pauses. This phenomenon usually represents a second degree AV block or non-conducted premature atrial contractions. Occasionally the sinoatrial exit block. So in this picture we can see there is progressive prolongation of the PR interval, condensing of the QRS complexes, In this ECG, we see QRS complexes. They are clustered in groups. They are separated by non-conducted P waves. P is to QRS conduction ratio is 5 is to 4, or we can say 6 is to 5. The difference in the PR interval between the first and last QRS complexes of each group can be noted. Mobitz type 1 AV block is at time is associated with inferior ST elevation MI and right ventricular infarct. In this ECG we can see 2 is to AV conduction. The majority of the rhythm strip shows 2 is to AV conduction, which makes discerning type of the block. It could represent Mobitz I or Mobitz II also. However, there is single 3 is to 2 Mobitz I cycle visible in the middle of the rhythm. If we can see, we will see 3 is to 1 Mobitz I cycle in the middle of the rhythm. Just see QRS complexes 5 and 6. Okay, if you look, you can see a non-conducted P wave deforming the downslope of the T wave in complex 6. Here, if we see, these are condensed QRS complexes, one P wave which is submerged with the T wave of the, and then we see non-conducted P wave. Conduction rhythm strips recording revealed that this patient has Mobitz type 1 block. This is another example where we can see Mobitz type 1 block in patient with atrial pacing following the mitral valve surgery. We can see small atrial pacing spikes preceding the QRS complexes. The interval between the pacing spike increases progressively until there is non-conducted P wave. To find out just we can see these ECGs from ECG exigency series post-op pacing puzzlers. Hippocrates has said, the life is too short, so craft so long to learn. With this, I conclude my today's topic. Thank you. Keep learning.